Okay, let's go with our lecture on spinal cord injury. Here are the learning objectives for today. You can read over those. And when you are in your PowerPoint in your slideshow, when you're playing it in slideshow mode, you should be able to click on this link for anatomy of the spinal cord. And I want you to take a review of that just to get that anatomy and physiology back in the forefront of your brain as we're talking about spinal cord injuries. So if you remember our spinal cord, that's our connection between our brain and our periphery, right? We need that to have our body move, and our brain is going to tell our body what to do. The spinal cord extends from the foramen magnum. Remember, we talked about that opening in the area at the base of the skull. We talked about that when we talked about traumatic brain injury. So extends from all the way up there down to the lumbar area. It's about 18 inches long. And then when we get below L2, we call that the cauda equina, and I'll talk about that in just a second. But our spinal cord is an H-shaped core of nerve bodies. So I'll show you a cross section. It's surrounded by our ascending and our descending tracts, and we have the gray matter and the white matter of our spinal cord. So that cauda equina, that area that I said was below our second lumbar area, that's a bundle of nerve roots. It's down at the bottom of our spinal cord. It contains all of our lumbar and our sacral nerve roots. So the importance in this really is this area provides our motor and our sensory function to bowel, bladder, and our pelvic organs, which control our sexual function. So think about a patient that has any injury above this area is going to have some type of deficit in this area. So deficit in motor and sensory function to bowel, bladder, or our pelvis. So this is an important area. When you look at that cross section of our spinal cord, if you can think of the mnemonic AMPS, AMPS, so the anterior area of the cord, the ventral horn, that has our fibers which control motor, our motor fibers, essential for our voluntary movement, our reflex activity of our muscles. And then the posterior area of the cord, our dorsal horn, that has area where there's the sensory nerve roots. This serves as our relay station. It's our sensory, our reflexive pathway, and proprioception. Do you remember that from health assessment? Proprioception is how you tell where your body is in space. If I would close my eyes and somebody would lift my arm up, I would know that my arm is up in the air. If you remember back in health assessment, you may have tested this on your partner by wiggling their toe up and down. Eyes closed, wiggle their toe up and down, and then, ask them, where is your toe now? Is it up, down, or neutral? That's proprioception. And that area is controlled in that posterior, the dorsal horn. So remember that AMPS. That's going to help you later on. Continuing the review, our vertebral column, starts up again at our cervical vertebrae. We have 7. We have 12 thoracic, 5 lumbar, and then down in our sacrum is a fused mass of 5 vertebrae. Again with the review, so thinking about our nervous system, the sympathetic and parasympathetic. Think about what each of those does. Our sympathetic nervous system is that fight or flight. It gets us ready for, something intense. We can have physical, emotional stress, and that can help increase our impulses. We'll dilate our bronchioles. If we have to run, we're able to get more air. Our heart beats stronger. Our muscles dilate, brings blood to our muscles, and our pupils can dilate also, letting more light in. The parasympathetic is that controlled opposition of the sympathetic, right? It helps to decrease our heart rate and decrease that force of that heartbeat. It helps to relax our muscles and our sphincters and helps to decrease our rate of breathing. So this will come into play also shortly. Patients with spinal cord injuries can have either upper motor neuron or lower motor neuron injuries. So the central nervous system influences the two, the activity of the skeletal muscles through both of these neurons. If the patient has a high injury, basically, above the thoracic level, cervical and high thoracic, but is the upper motor neuron. So that originates up in our cerebral cortex, and it does modulate the activity of our lower motor neurons. Our lower motor neurons are in our anterior horn of the spinal cord, and they need to be excited by those upper motor neurons. So both are important. If a patient has a high thoracic or a cervical injury, the patient will probably exhibit loss of voluntary skillful control. So they might not have that, motor control. They'll lose dexterity. Their involuntary reflexes are uninhibited. So that causes a spastic type paralysis. Often when people think of paralysis, you think of flaccid, but an upper motor neuron injury gives you spastic paralysis. So these patients will be very hyperreflexic. They'll be in a clonus state. So their muscles won't necessarily atrophy because they're in that tense state all the time. These patients also will exhibit a Babinski reflex because they have that hyperreflexive injury. The lower motor neuron injuries, those come from a lower thoracic injury or lumbosacral. So those patients have that flaccid paralysis where there's no muscle tone, muscles are, very soft and flat. They will have atrophy, and these patients are hyporeflexic. And if you attempt to do a Babinski, if you remember that plantar reflex where you're rubbing, something up on the foot and you're expecting, the toes should be curling down on an adult anyway, that's going to be negative on a patient with a lower motor neuron injury because of their hyporeflexia. Just looking at some of the statistics for spinal cord injuries, these are devastating injuries. When you look at these statistics, and this is from 2019, 18,000 new injuries in a year. People in the prime of their life, their injuries from 29 to 43 years. They're starting to get older people that are injuring themselves. But again, younger age, male, alcohol use. And most of the injuries are incomplete tetraplegia. So we'll talk about complete and incomplete. But when you think of tetraplegia, that is affecting all four of your limbs. And when you look at most of the reasons how patients have spinal cord injuries, car crashes are at the highest, followed by falls, violence, gunshot wounds, and then there are also sports injuries. And we've talked about this before. As nurses, we're responsible for our education, and primary prevention really is the key. And we now have, I've talked about this before, seatbelt use, airbag use, things that are helping us to lower some of those injury statistics. And education, the traffic laws, speeding, speed limits, cell phone use, helping to decrease those car crashes, use of seatbelts, helmets, and then promotion for anti-violence. Water safety, there is, a group that goes out and talks to kids feet first time. If you're jumping into a lake or, something that you can't see the bottom, jump in with your feet first the first time to know how deep it is or how shallow it is. Not diving headfirst into a pool that says do not dive. Everybody thinks that they're going to dive shallow, but it's that one time that you make a mistake. We see injuries coming from people diving into the ocean. The wave is at the height at the time the person dives, and by the time they get in the water, the wave went out and they hit their head and they have a devastating neurologic injury. Fall prevention in our elderly patients, firearm safety, and then proper coaching and training for our school sports. So, that makes me think about often football, especially younger players, how they're not going into a tackle with their head, going in with their shoulders first. Okay, let's go into our pathophysiology. So when you think of how we can get a spinal cord injury, how does it occur? Various mechanisms. And also you can kind of think about this almost in the same vein as when we talked about traumatic brain injury. So you can have a concussion of the spinal cord. It was hit, and it kind of has that shock of it. That's often a transient. You'll see transient symptoms from that. There can be a contusion, a bruising of the spinal cord, laceration. We can have compression of a spinal cord. The cord can be transected. There can be hemorrhage into the cord, and then also ischemia. If we don't have blood flow, blood and oxygen flowing into the cord will become ischemic. Looking at the mechanisms, when you look at these photos here, so the photo on your left, the hyperflexion, so that can be, a car crash where your head is being shot forward and then backward. You have that hyperflexion where it's really bent severely and the vertebrae may actually push into that cord area. Same with the hyperextension, that flexion of the head. Remember, we talked about it with traumatic brain as coup and contre coup, or acceleration, deceleration. So it's the same type of movement, but now, you might be thinking about your vertebrae actually being bent so hard that they're pushing into your cord. We can have compression injuries. So those are often from falls, depending on how the person falls. So when you see this man who fell off the ladder here, there's that compression, the bone, so much force was put on his bottom there that it compressed some of those vertebrae together, which in turn is damaging the cord. And then the bottom picture there is our person who dove into a lake or a river and didn't realize that it was not deep enough because they didn't go feet first time. And that's compression from the top. And it's damaging those vertebrae, pushing into the cord and causing cord damage. This is just another picture of how our vertebrae can be fractured, again, pushing into that spinal cord, causing injury. And when we look at our most frequently injured vertebrae, often they're the vertebrae that have the greatest range of mobility. So up in our cervical area, C5, 6, and 7, usually around T12, and our first lumbar. Those are, the areas where we really have a lot of mobility. So, vertebrae can be damaged there, which in turn is going to damage our cord. And you'll see this dermatome man in various places. So not that you need to memorize him, but you're going to look and see, what is really important, especially in our movement related to our activities of daily living. And we'll talk about that. So what manifestations do we have for spinal cord injury? What does it look like? So I told you a patient can have a complete or an incomplete injury. A complete injury really is exactly what the term says. It's loss of all sensory and all voluntary motor communication from that brain to the periphery. So any sensation or voluntary motor communication is gone. So this, depending on where the injury is, it will result in a complete paraplegia or tetraplegia, depending on where we have the injury. The incomplete, which is the most common, is, there's an injury somewhere in the cord, but there's some function or movement is preserved. It's not a fully complete injury. The sensory and the motor fibers may be preserved below the level of that injury, so the patient may have some sensation and some type of motor activity. And just like with our traumatic brain injury, where we had primary and secondary injury there, same thing can occur with our spinal cord injured patients. So the primary injury is that initial trauma. What happened initially to the patient? This is the initial injury to this patient's spinal cord. That it will not be reversed. You'll see, in the cord, you may see there will be petechial hemorrhages in the gray matter. They can see that in MRI. There may be edema, which would cause necrosis. And that secondary injury, again, just like traumatic brain injury, we as healthcare workers, we are trying to prevent any secondary injury. That's going to worsen that primary injury. It can be a result if there's a tear in the cord and now, the impulses can't get through, blood can't get through, oxygen, the cord can swell. Release of vasoactive agents are damaging the cells in the cord. Again, if you have lack of blood flow, if the patient is hypotensive, hypoxic, that will send, that in turn will affect the spinal cord, hypoxia of the spinal cord. So there's no oxygen getting to that cord, which in turn is going to cause edema. You can have the cord itself swell. There can be bleeding into the spinal cord, hemorrhagic lesions. And all of this can lead to neural damage. Those neurons are being damaged, and there can be scarring and death of the tissue. And this really is what we are trying to prevent as healthcare providers, trying to prevent that further injury for our patients. So what does it look like when our patients have a spinal cord injury? If you're reading your patient's chart, you may see, especially the physiatrist will speak this language, and our physical therapists, the ASIA scale, American Spinal Injury Association. This is a language mostly our rehab people will talk, and this gives you the degree of sensory and motor function that is present after the patient's injury. And I'll go over that in a bit. It's just something for you to know, and when you see it, that you'll be familiar with it. The term that I do want you to fully understand, neurologic level. This is the lowest level at which sensory and motor function are intact. So let's say your patient has an injury at C6. Their neurologic level should be C5. That's where they are intact to. After that, there's going to be, some motor or sensory malfunction. So below the neurologic level can be total or partial. Remember, we talked about complete or incomplete injuries. So total or partial sensory or motor paralysis. The patient can have loss of bowel and bladder control, which usually presents like a urinary retention, bladder distension. The patient can have loss of sweating and vasomotor tone below that level, reduction of blood pressure because the vascular resistance now is gone, so it's difficult for them to maintain a blood pressure. Patient can have loss of pain, light touch proprioception, loss of somatic and visceral sensations. Somatic is our pain. Visceral is that internal, our organ pain. Like if we have a full bladder is a visceral sensation, bowel is a visceral sensation. And then the patient also has loss of ability to maintain their temperature. That's called poikiloothermic. So this is important in our spinal cord injured patients. If they are sitting under an air vent that's putting out hot air, warm air, or cold air, they can't adjust their temperature. They are going to take on the ambient temperature of their surroundings. So we need to be really careful with our spinal cord injured patients in that way. This is just a look at where, if some of the injuries occur, what do we call it? What do we document it? So those higher injuries, the cervical injuries, are tetraplegia because our patients will have involvement of all four limbs, arms and legs. And then when you get to the lower injuries, the thoracic, mid-thoracic and down, this is generally a paraplegia. Our patients that have paraplegia, so that's going to result from an injury or a lesion that involves the thoracic lumbar or the sacral spinal cord. And these injuries will have some type of dysfunction of the patient's lower extremities as well as bowel and bladder dysfunction. Our patients that have the worst injuries are quadriplegia, or also called tetraplegia. So that is resulting from an injury up in the cervical segment of the cord. So this is going to give our patient a dysfunction of our upper and our lower extremities as well as our bowel and bladder. So, devastating injuries when you're thinking about different types of spinal cord injuries. And again, remember, these patients can be either complete or incomplete. So this person can have complete loss of sensory and motor, or possibly they may just have, a decrease in their motor function on their upper extremities. Maybe not fine motor, not dexterity of the hands, but there is some type of loss of motor or sensation in all four of the extremities. This is a pictorial of some different types of lesions that we can have in our spinal cord. So there's a picture of that complete lesion up on the top left. So we're going to have that total loss of motor, sensory, and reflex. Anterior cord. Now again, think back to that AMPS, and we'll go over that in just a minute. But if we have an anterior cord injury, you can see how that would look. Some damage to the front part, the ventral portion of our cord. We can have Brown-Séquard, so there's injury on half of our cord. And then central cord, there's injury on the inside of the cord, and that's typically an incomplete loss of our motor function. So just to go through those a little bit more clearly, the anterior cord syndrome. So think about that AMPS. We said anterior cord, that's our motor area. This is often from the hyperflexion injuries where our neck really is, moving forward and backward. It can be a disc herniation. We can have an anterior spinal artery injury. So the patient will exhibit here below the level, wherever the cord is injured, below that level. They're going to have motor paralysis, remember, anterior motor. They'll also have loss of pain and loss of temperature sensation. But the posterior portion of the cord may be preserved. So they'll have preservation. They'll still have that proprioception we talked about. Remember where your body is in space. They'll have the sensation of vibration, and they may have some light touch sensation. Our patients with central cord syndrome, that can be caused by swelling to the area, typically up in the cervical area. And you may see deficits in the upper extremities. And this one is strange because you think if they have deficits in the upper extremities, then they also will have them in the lower extremities. But in this type of injury, the injuries are more pronounced in the upper extremities. So the patient may still have normal or just slightly decreased motor deficits in the lower extremity. So, their upper looks worse than the lower. They will probably have bowel and bladder dysfunction, but that's variable, exactly what they'll have. And then we have the Brown-Séquard syndrome. That's also called lateral cord syndrome. So that's from an injury on one side of the cord. It can be from a transection, like a knife injury, a bullet, if there's a fracture. So this injury, this is really It's very interesting when you can see someone diagnosed with this and you look at their neuro exam. So ipsilateral, same side, that's the same side as the injury. They will have paralysis on the same side, paralysis or paresis, that, loss of sensation, loss of touch, pressure, vibration. But they still have their pain sensation on that side. On the opposite side of the injury, the contralateral, now they're going to have loss of pain and temperature on that side, but they may have preservation of their motor on that side. So this one is really complicated to diagnose, but it's very interesting when you see this assessment being done. When you think about emergency management of these patients, it really is the same of all of our trauma patients. So the patient needs proper handling at the scene. That's why our ABCs are always airway with C-spine stabilization, because you never know. You're going to, think that the patient has a C-spine injury until it's ruled out. So proper handling at the scene and moving the patient to prevent any further injury that they may have. You're going to immobilize them, especially during extrication. So often if someone is trapped in a vehicle, they'll put a collar on them before they even get them out. Keep that head in that neutral position. It's extended, so it's always in that neutral position. Hands on both sides of the ears down to the shoulders to prevent twisting until you can get that collar on them, or a backboard with something that prevents their head from moving around. The patient is always placed on a firm bed. They're never placed on an air mattress right in the initial stages until you know about any spinal cord injury. Rotarests and strikers are specialty beds that may be used. You may see them. I have a picture of those. So the two left pictures are rotorest beds. So patients can be placed in. You see on this bottom photo, you can kind of see the patient in there. Those are for our unstable spines, because the patient can be turned right in the bed there. And then on the right side is a circle bed and striker frame. You may or may not see these. Some of the older hospitals may still have these, and these beds turn the patients over. And I think I showed you that, I forget what lecture, but I know I had that bed in one of the lectures. ARDS, I think, to flip the patient over. Those are some older beds, but you may still see them. How do we diagnose our patients with a spinal cord injury? Really, you can almost diagnose with just your neuro exam. So if you are doing a good motor and sensory exam, you can, for the most part, tell where your patient's injury most likely is based on that before you even see a CAT scan or an MRI. So you have to do a good spinal assessment. And that's assessing both the motor activity for the patient and their sensation. Remember back to health assessment when you assessed sharp and dull. So you would be assessing these patients based on that dermatome man, and see where they can distinguish that sharp and dull, and where that ability to distinguish that goes away. Patients will have lateral cervical x-rays. They can have spinal x-rays, definitely CAT scans, can look at the vertebrae. MRI can look at the cord. And often these injuries come along with other injuries. So, you still need to look for other injuries in addition to the spinal cord injury. You want to continuously monitor these patients with EKG, and you're monitoring for bradyarrhythmias that can come as a result of other injuries or as a result of the spinal cord injury itself. When you are assessing the patient, again, airway with C-spine control, and you really want to monitor their breathing. We're going to talk about where the diaphragm is innervated from the spine, and how spinal cord injury will affect our patient's breathing. You're going to do a very detailed neuro exam. We talked about that Asia impairment scale, and I'm going to go into that in the next slide. But you want to look at your patient's motor strength. If you are having them shrug their shoulders or do flex their arms up, what is their strength? And the strength, this is an objective measurement. So 5 is normal. 4 would be against gravity and some resistance. 3, the patient can still move against gravity, but no one is giving them any resistance. 2 is the patient now cannot go against gravity. So they're moving in the same plane. If you ask them to lift their arm and they're laying in a bed, they may just move the arm kind of side to side along the bed, but they're not able to lift it. So 2, there's no gravity. And then 1 is usually a slight muscle flexion. You can see some type of movement in the muscle, but the patient isn't able to move the limb or whatever you're asking them to move. And then again, that sensory level, and that's your sharp and dull. Is the patient able to differentiate sharp and dull? And you may assess a patient early on, and when we talk about that secondary injury, if we don't prevent secondary injury to our spinal cord, the patient may have, let's say they have some sensation down to C7 area. Maybe now their cord has become hypoxic, or they've had low flow, hypotension, and now edema and hypoxia to that cord has ascended, gone up the cord, and now their deficit may be higher. So you need really good spinal cord assessment and good documentation of that. This is the Asia Impairment Scale. This is just for you to have an idea of what it is. You don't need to memorize the levels of this. And again, this is used often for rehab and how the patient, where the patient should go, what's the correct rehab, and, helping with prognosis as well. So we talked about the dermatome man, and again, we need that accurate neuro assessment. You want to have your patient's eyes closed because obviously they really are, they want to be able to feel something. So you're going to have their eyes closed. You assess them bilaterally. You're doing sharp and dull. You're starting from the top and going down, and you can, do it with, an open paper clip, something like that, that's going to give them the sharp. Even if you have to show them on their face where they can feel this is what sharp feels like, this is what dull feels like, and then close their eyes and they say where they are feeling it and if it's sharp and dull. And then again, that motor. And we're going to talk about, what are you going to do? You need to know what each level, what motor activity you're going to ask your patient. C4 is a shoulder shrug. C5 is bicep flexion. C6 is wrist extension. C7 is your tricep. So you're going to have your patient push their arms down. And then around C8 is their grasp and the ability to abduct their fingers. So think about all of those cervical movements and how important that is in your patient doing their activities of daily living. Can they get a spoon up to their mouth and then back to the plate? They would need both their bicep, their flexion, and their extension to move. So you're monitoring the trends, good documentation, and if there's a decrease in function, you're notifying the healthcare provider because possibly that spinal cord injury may be progressing. And this is our dermatome man. So again, if you're doing sharp and dull, if the patient has intact sharp and dull differentiation up on their shoulders, then they're intact at C4. You can go down the outside of the arm, outside of upper arm, outside of lower arm. Their middle finger is their C7. Interior arm here is T1. So all of those areas represent a different place on the dermatome, and you would just differentiate sharp and dull. And in EPIC, there's a really very specific spinal cord assessment that you can look at in EPIC. Ask your clinical instructor to show that to you, and you would be able to do that on your patient. And this is just showing you, again, some of those key muscles. So your elbow flexors, your wrist extensors, and everything that I just said as far as cervical. And then down lower in your lumbar area, your hip flexors. Ask your patient to bend their knees up, extend the knee. Maybe if you get their leg up and then see if they can kick out with their knee. And then your plantar and dorsiflexion going down lower. Some of the landmarks, remember I said, where is our diaphragm innervated? So an injury at or near C4 is going to affect our patient's diaphragm. So even if you have an injury, let's say at C6, and if that patient isn't well cared for and that injury ascends up the cord, that can give the patient some respiratory difficulty. So any cervical spinal cord injury, your main focus is going to be the patient's respiration. You really need to pay attention to that. We need our respiratory muscles in order to breathe, to cough, to take big, deep breaths. So this is super important in possibly keeping our patient off the ventilator and causing them more respiratory distress. T4 is generally at the nipple line, T10 is at the belly button, and then our perianal and down into our sacral area. If there's any anal contraction, any contraction of the sphincter, then we would call that injury an incomplete motor injury because they still have some type of ability to contract there. So in the acute phase, again, we're maintaining those respirations. We really want to be very cognizant of where our patient's spinal cord injury is, knowing what level does what to our patient. We want to prevent any type of shock, hypovolemic shock especially, because again, that low flow, low oxygen to our cord, just like to the rest of the body, is going to cause secondary injury. We want to immobilize our patient's neck. We're preventing any further damage. We're watching out for any complications that our patient is going to have, and I'll go through those. Bladder retention, deep vein thrombosis. And these spinal cord injuries, as I've said, are devastating injuries. They do have permanent effects, even if it's not complete. Even an incomplete injury is a permanent effect, which will affect the patient's rest of their life. There's 3 different interventions: pharmacologic, our skeletal traction, and then our respiratory therapy. So let's talk about some of that. Airway and breathing, always so important. So we want to deliver oxygen. We don't want these patients to be hypoxic because that can worsen that deficit. If the patient needs to be intubated, it's with extreme care because you cannot flex that neck like this guy actually is in a flex position. Or an extreme extension. You can't do that. You need to keep their neck in a neutral position. And again, we're thinking that diaphragm is innervated at C4. So any injury near that area is going to affect our respiratory status of our patient. Pharmacologic therapy, I have this here because your book does still talk about it. It is not used much anymore. Really, the studies, the research doesn't show that there's a benefit. But in the past, when I started nursing, this was standard with any spinal cord injured person. And really, depending on where you go and depending on the surgeon, you may still see it. But basically, it's a methylprednisolone drip that your patient is on. They would load them and then they would give a continuous infusion for over 24 hours, thinking that, this is going to decrease the edema in the cord. But there's also, complications with it. Our corticosteroids, obviously not good for our stress ulcers, not good for our blood sugar. So this really isn't used much, but you may see it. So I just wanted to, let you know about it in case you heard of it. Our skeletal traction. So some patients with cervical injuries may be put in cervical traction. So this reduces the fracture, puts the vertebral column back in alignment and stabilizes. And this is until the patient is generally either put in a halo traction or has surgery. So Gardner-Wells or Crutchfield, those are the type of traction that's, the patient is in the bed, just like these 2 pictures or 3 pictures that you see. So they start off with a very small amount of weight, so maybe a ½ pound to 1 pound to 2 pounds, and then they do cervical x-rays and see when that vertebral column is in alignment. And they'll monitor that, make sure the vertebral column is in alignment. And often the neuro exam may improve if the patient has had some numbness or tingling in their fingers or something. Once their vertebral column is in alignment, that may be better. The patient may have less numbness and tingling. And again, this is temporary. They can't stay like this for any length of time. And this is generally until they'll have surgery, a surgical fixation of those neck fractures. That's just another picture there of our cervical traction. Traction that we can send patients home with is a halo device. I don't know if any of you have seen that, but that's that stainless steel ring. It's fixed to the skull, and then it's attached to this vest. And it immobilizes that cervical spine. And patients may be in this contraption for 12 weeks, but they can get up, they can ambulate with this, and they're able to go home. So you need to have good pin care. The pins should not be moving at all. They are snug into the skull. They go into the skin and just into the skull. So you may have a little bit of drainage there, but it shouldn't be purulent drainage. The pins do not move. You need a special screwdriver that you keep with the patient all the time in case you need to get them out of that for any reason. You want to give really good skin care. They take a shower with this, and then they take that fleece part out. The fleece part just Velcros into that white plastic part. So you shower, then you take the fleece part out, and you would have a second set of fleece that you would put in. But watch their good skin care. And then you know what to do in an emergency. On this photo, if you see the writing on the front of that white part, that basically says what you do in an emergency in CPR. This white part bends. There's like a crease right around here. If you can see my cursor, I'm not sure, but there's a crease right around where that writing is, and you would bend up that white plastic part, and you would get in to do CPR. So if you have a patient with a halo, you need to be cognizant of what you would do in an emergency. And it does happen. Yes, I can tell you I've been in that situation. So you do need to know what to do. But that's our halo. So they can walk around with that and get home and get back to their activities. But they are in this generally for about 3 months. If the patient needs surgery, they may need a decompression of the cord if the cord's being compressed. If there's any pieces of vertebrae in there, compound fracture, sometimes an injury that involves a penetrating wound, they can have the bony fragments in there. If the patient is deteriorating, they may need to decompress that fracture and elevate it. Typically with lower thoracic and lumbar injuries, those are just immobilized with a brace. So you may see those in the clinical area. And where I have here TLSO, that's the brace, thoracic, lumbar, sacral orthosis. So the brace just tells you what area the person is being immobilized. It can be an LSO, lumbar sacral orthosis. And generally there's no traction for the lower injuries. It really is mostly just the brace. This is just some pictures. These are pictures of some of the surgical fixations you might see. These are some of the braces you might see. And you always need to pay attention to your patient's order. Do they need the brace if their head of bed is, let's say, for example, higher than 30 or 45 degrees, or is their brace ordered just for comfort? If it's just for comfort, you can sit them up and put it on. If they need the brace, if it's ordered for head of bed, higher than whatever, you need to put that brace on before you sit the patient up. So always know what your doctor's orders are. Let's talk about some complications from spinal cord injury. So one of the biggest early complications, spinal shock and neurogenic shock. And sometimes you'll see them used interchangeably. Spinal shock is a depression of that reflex activity below the level of the injury. So the muscles have no sensation and they're flaccid. So the spinal cord is in shock. Everything's flaccid. There's no reflexes. You'll see the patient will be hypotensive, and they'll also be bradycardic. So we already talked about we don't want that to happen because that's going to lead to further injury of our cord. So we have to be really careful with that. The patient's also going to have bowel and bladder function affected because everything is essentially flaccid below the level of the injury because the spine is in shock. The patient will also have a paralytic ileus at this time. Neurogenic shock is that loss of autonomic nervous system function below the level of the injury. So again, we're going to see severe bradycardia. We're going to see severe hypotension, which is going to lead to a low cardiac output. This hypotension is typically refractory to fluid. So if you're thinking hypotension, I need to give my patient a fluid bolus. This doesn't work here. Again, the cord is in shock. So you're going to have peripheral vasodilation. If you think of your blood vessels being just flaccid and lazy, think of everything as paralyzed below the level of the injury, even your vessels. So how do we maintain a blood pressure? We maintain blood pressure by our vessels constricting. Well, now we have vasodilation. So we have this venous pooling. So these injuries, the hypotension, you can't give fluids. That's not going to help. Often you're going to have to use vasopressors here. The patient will be bradycardic. They may need atropine or maybe even a pacer. The patient will show no sweating below the level of the injury. And if it's cervical or upper thoracic, again, we need to think about our respiratory issues because now all of our respiratory muscles are affected. This can last for, up to weeks or a few months right after the injury. As our patient's reflexes start to come back, that's a recovery. That shows recovery of our neurogenic shock. So the bulbocavernosus, if it's a male, and if you tug on the Foley, and then the testes will rise. The perianal reflex, if you prick around or touch around the perianal area and you have contraction. So that's reflexes coming back. As the reflexes come back, your neurogenic shock is starting to improve. So that's something that you always want to watch out for as well. When is our neurogenic shock getting better? And, you also need to keep in your mind when you have a new spinal cord injured patient that these things are probably going to occur and you need to watch out for good assessments. Other complications of our spinal cord injured patient is VTE. Our patients, they're not moving. They don't have any active range of motion in their legs. It could be in their arms as well. So they are at increased risk for deep vein thrombosis. They can't feel it. They can't tell you that their calf is painful or their calf feels hot. They can't detect that pain. So we need really good assessment skills. If the DVT actually moves into a pulmonary embolus, our patient might have some pleuritic chest pain. They might have shortness of breath. They can be hypoxic. So we want to keep our level of suspicion up in these patients when they have respiratory issues that they may have a PE. Most often, unless there's a contraindication, the patient's going to be on a low-dose anticoagulation, Lovenox or heparin. All of our spinal cord injured patients will have anti-embolism stockings or TED stockings. This is highly important for our patients, our SCDs. And then if there are patients who, for some reason, can't have anticoagulation, they may have an indwelling filter put in. So an IVC filter goes into the inferior vena cava, just like this picture, and it's there to catch any clots that may occur. And again, as part of our nursing assessment, we want to pay close attention to our patient's legs. Is there one leg that's larger than the other? Does one look warm or hot? Is it firm? And, just a good level of suspicion for DVT and good nursing care as far as prevention. Again, the cervical and our high thoracic injuries, these patients are going to be highly susceptible to atelectasis. Their accessory muscles may not be working correctly. So these patients, the leading cause of death is respiratory failure. So that is part of our nursing. Our nursing care is to prevent this. So what are we going to do? We're going to have close monitoring of our respiratory status. If the patient needs intubation, we're going to do that, give them ventilator support, suction the airway as needed, monitor their vital capacity measurements. That's usually respiratory will help you with that. How can the patient take deep breaths? How good are they doing? Is it decreasing over time? Provide incentive spirometry and help them with it. They may not be able to hold the incentive spirometer. You might have to help them with that. You might need an abdominal binder to help them, just to give some pressure in order to help them to cough. Aggressive pulmonary care. So that's turning our patients every 2 hours, possible percussion, getting those secretions loosened up, suction when they need it. But again, it's that basic pulmonary care that we need to do for our patients. And then quad cough. And I do have, all right, hang on with the quad cough a second, but here's our abdominal binder, percussion vest. So that's a vest that goes on the patient and it kind of jiggles them. It percusses them to help loosen up those secretions. And then you would help the patient cough or suction them if they would need that. The quad cough, I'll let you watch this little video here, but what it does is it helps your patient to cough. Patients that have some type of upper injury, upper spinal cord injury, that is preventing them from having a good, strong cough. So the patient takes a deep breath in and out, and then it almost looks like the Heimlich maneuver. That's kind of what it looks like. And you're going to give a thrust that's going to help them to cough. So take a look at this video, and this is really super important for your patients with spinal cord injury, and that you as the nurse are assisting your patient with this. You're going to maintain good skin integrity. They cannot move. Often, maybe they can't move at all. They're total tetraplegia. So skin breakdown is very common. Pressure ulcers. You have to monitor their bony prominences. Make sure their nutrition and their hydration is good. You obviously may be helping them to eat if they're not able to eat. Repositioning. Teach the patient or family member shifting. Even if they're sitting in a chair, they have to shift their body every hour, every 2 hours. They can't sit in the same position. You want to avoid any shearing when you're pulling them up, and they may be on specialty beds if they have fractures, once they're fixed. And then you're going to watch their Braden score to see, that might put you in tune that they need a specialty bed if their Braden score is changing. You want to help promote any mobility that they can. You want to use passive range of motion if the patient isn't able to do it at least 4 to 5 times a day. You want to keep those joints mobile. You're going to monitor their blood pressure with their position changes. We're going to talk about orthostatic hypotension, and maintain the patient in good body alignment, especially those patients that have that spastic paralysis. So we talked about the spasticity. That's that, increase in muscle tone. The patients may need, like you see here, this, the grip for the arm to keep everything in a nice alignment. They have hyperactive deep tendon reflexes. So this usually will show after the spinal shock resolves. So you may see this in your patient. Good range of motion, proper positioning. Occupational therapy, physical therapy is a must with these patients to keep everything from getting, too tense, and to keep things mobile. There may be medications that can be used for the spastic paralysis. Baclofen is a common medication, antispasmodic, that you can use in the patient. And then the other ones, Valium, also dantrolene would be, for a spastic bladder. Maintaining our bowel and bladder for our patients. So the patient initially will be atonic. If they're in spinal shock, they're not going to have any tone to their bladder. And, patients that have retention, they can't detect that visceral pain that I talked about. They can't tell that their bladder is full. So that's up to the nurse. Assess the distension, whether you're visualizing, whether you're using a bladder scan. The patients may need intermittent or an indwelling catheter, good INO, good hydration, and we're monitoring for urinary tract infections. The patient won't be able to tell if they have burning urine, but you would teach them monitor for any foul smelling urine. What does their urine look like? If they're in the hospital and you're doing their lab work, are you watching their white blood count? So all of those things you need to think about. And then autonomic dysreflexia, we're going to talk about that. Our bowel the bowel complications that our patient is going to have, especially in the beginning. They may have paralytic ileus, so they'll need a nasogastric tube. We want to prevent our gastric ulcers, so all of our patients will be on stress ulcer prophylaxis. We want to watch for any sphincter tone, assess for that, see if they have it, and then start a bowel program for our patient. These patients will need bowel program for when they're going home. So they'll need good hydration, high fiber diets. They'll be on stool softeners, and then they're taught digital stimulation, and they typically can get on a bowel program where they can, have their bowel movement early in the morning, or they can have it later in the evening, and they'll get on some type of program for that. Managing a neurogenic bladder. So our patients that have those upper motor neuron injuries, that's those spastic injuries. Think about spasticity and think about if your bladder is spastic. And again, the patient doesn't have any sensation or motor control, and the bladder may empty on reflex, but the patient can't control it. So think of a spastic bladder. It can be urinary frequency. The patient may be incontinent, but they're not going to be able to empty their bladder completely. So we have to teach them, how they may, assess that. Helping them to reestablish their voiding patterns. So triggering or facilitating. Sometimes just stroking on the inside of the thigh or on the lower abdomen may help to trigger. So that may help the patient to void at that time. There may be some of the bladder spasm medications ordered. They may need intermittent catheterization, and then establishing that toileting schedule, helping them that they have enough fluids so that they, aren't going to get a bladder infection because of low fluids. And then as a last resort, our indwelling catheters. Obviously, we don't want that if we don't need to, because that's going to, help increase our chance for infection. Our patients with the lower motor neuron injuries, now remember, those are flaccid paralysis patients. So those bladders may fill and then over distend. So the patient will have urinary retention. And again, trying to reestablish those voiding patterns. This may be Valsalva. The patient may bear down to try and get some of the urine out. Crede is where you can gently rub or massage on the bladder to try and empty it. Again, increase fluids, and then that intermittent or indwelling if we need it. Orthostatic hypotension is a complication of our patients. So again, think about we have vasodilation in these patients. So sometimes even the slightest movement will give them a drop in their systolic blood pressure when they're vertical. So drop in blood pressure is going to decrease the preload, what's coming to the heart, and then is going to decrease our cardiac output. So the patient will become syncopal. They can have cerebral ischemia, and they can actually have stroke, infarction from this. We're going to monitor our patients' vital signs before, during, and after their position changes, especially early on. We're going to optimize their fluid status. Use our TED stockings. They will have thigh-high anti-embolism stockings. Abdominal binders are very helpful here. And then you're going to plan out your activity. So you're not going to just get the patient up very quickly. You may have to sit them up, slightly, 30 degrees, then go to 45, and then sit them up, slowly in order for their body to kind of maintain that equilibrium. And they may need to be on medication to help with the orthostatic hypotension, in addition to all of the things that I just talked about. Let's talk about autonomic dysreflexia. This is a severe complication that our spinal cord injured patients can have, and this can be for the rest of their life. So patients need to be educated on this. This is an emergent hypertensive event. It occurs once that spinal shock is resolved. So again, think about we talked about spinal shock and how do we know that the patient is coming out of that when those reflexes are coming back. So once that happens, you then need to think about, oh, now my patient can have autonomic dysreflexia, and know what the signs and symptoms and the treatment are for that. Typically, this happens to our clients that have injuries at T6 or higher, so some of our higher injuries, and it's caused by anything that aggravates the patient, any noxious stimuli. And the stimuli is going to cause an exaggerated sympathetic response. That's what autonomic dysreflexia is. It's that exaggerated response. Most of the time, most common cause is bladder distension. So our patient may have a distended bladder. They can't feel it. They don't have that visceral pain ability. So the bladder is distended, which is sending up that exaggerated sympathetic response to our brain. Another cause, the two most common causes are bladder distension or fecal impaction. It can be a DVT, urinary tract infection. The patient can have a pressure ulcer. It can be maybe the patient is laying on a wrinkle in the bed sheet, and that can cause it. An ingrown toenail, menstruation for women. If clothing is too tight or their shoes are too tight. I had a patient one time that the family put sneakers on the patient and the shoes were too tight. It can be heat or cold. Maybe the patient is sitting near a heating vent or near an air conditioner, and they can't feel it, that their body is feeling this aggravated heat or cold, but it's sending that reflex. So when it sends that sympathetic response, the patient is going to show a severe hypertension, like severe blood pressure is going to go sky high. The patient will become bradycardic. They'll have a pounding headache. Typically their face gets very pink and red. They can have sweating above the level of the injury. So flushing and sweating above the injury. Goosebumps. That's piloerection is the name for goosebumps. So they'll have goosebumps above the level of the injury. They can have blurred vision from that high blood pressure. So these are the signs and symptoms of our autonomic dysreflexia. And remember, you want to, pay attention to that once your patient's reflexes come back and there's that chance for the autonomic dysreflexia to occur. So what are we going to do? First and foremost, you're sitting the patient's head of bed up. You're going to get their head up, which is going to help, kind of bring their blood back down into their lower extremities, hopefully. And then you need to find what's the noxious stimuli. You're going to look, do they have, if they don't have a Foley in, you're going to assess their bladder. Do they have bladder distension? If so, obviously you're going to catheterize them. If they have a Foley in, you're going to see, is that Foley patent? Are there any kinks in the Foley? Does the Foley need to be irrigated? Maybe the patient has had a urinary tract infection and there's some sludge in there. Get in and look at that Foley and make sure that everything is patent. Does the patient have a fecal impaction? Look at their skin, turn them. Are they laying on something underneath them? Again, go through the clothing. Are they near an air vent? Anything that's noxious, you're going to try and eliminate the noxious stimuli. Then you need to manage the hypertension. So often once you would straight cath or remove the fecal impaction, they do start to get better pretty quickly. But if not, generally nitrates. So you may use nitro paste, or hydralazine is another common medication that will help to get that blood pressure down. But you really want to monitor that blood pressure closely until the autonomic dysreflexia is resolved. And then you're going to teach the patient, what are the signs and symptoms? How do they prevent it? Most of the time, patients with spinal cord injuries, they are very aware of this, so they know what their signs and symptoms, they know their body. And they may carry, catheters along with them if they would need to be straight cathed, if that's one of their common causes. But that's up to us to teach the patient about their autonomic dysreflexia. Another complication, heterotropic ossification. This is an overgrowth of bone from disuse, frequent hips, knees, shoulders. Patient goes to radiation therapy, so you may be taking your patient down to the oncology radiation. They'll have treatments done to prevent this overgrowth. And if it gets too bad, they may need surgery to relieve this. Long-term rehab, patient, they're gonna, their goals shift as time goes along. But really the teaching begins right in the beginning, teaching about what adaptability, what can we provide them maybe for their ADLs, it might be something to hold a spoon or a fork or, different things, what can we support them in doing and what skills can we give them for self-care. It's going to be a multidisciplinary approach. PT, OT, the rehab team, really the ultimate goal, if the patient is able, is to be some type of independence, even if it's in the simplest thing. Discuss their sexual function and how, the patients may still have a life with sexuality into it. Good psychiatric support. Obviously, this is devastating and it's a life change, so they'll need psychiatric support and counseling. Alcohol, drug use support. If this was an issue prior to the injury, most likely it will be exacerbated afterwards. So what can we do to help the patient with that? Obesity, when you're thinking nutrition with these patients, generally they don't need more calories or more protein because their activity is less. But, if they're caring for a wound, let's say they have a pressure sore, then they may need more protein at that time. But we want to prevent obesity because if they are trying to transfer themselves, the heavier they are, the worse that's going to be. So long-term rehab is super important to get these patients back to a life. Strength training. If the patient has the ability, to have any motor strength in their upper body, we want to really strengthen that and give them maximum strength so that they're able to transfer themselves. Assist them with early mobilization if that's possible. Teach them to use mirrors to inspect their skin to watch for those pressure injuries, and then help them to adapt their home for safety and see what kind of vocational rehab we might be able to offer them so that they can continue in a job or a career. These are prism glasses, just helping a patient to read flat, essentially. Hippotherapy has shown some positive aspects. It helps the patient to stay upright. I do have, there's a link in the Canvas course for a barrel racer who was paralyzed, and she was able to get back up on her horse and go and do what she loved. So take a look at that. Basically, education, prevention, and research is so important in spinal cord injuries. And Christopher and Dana Reeve, if you don't know about them, you can check out their foundation. They raise a lot of money for research. And these are some of our key points for spinal cord injury. You can take a look at Nick's story here. If you have any questions about this lecture at all, please bring them into class when we do our simulation or send me an email, and I'll be happy to answer them for you.